From now on, feel like I'm in heaven. Not the toleration. I
చేసేటప్పుడు మొత్తం 10 minutes మాట్లాడడం కదా. 10 minutes 5 minutes మాట్లాడదాం, దాని తర్వాత గ్యాప్ ఉంటుంది కదా. వాళ్ళు ప్రెజెంటేషన్ చేస్తున్నప్పుడు ఎవరైనా ప్రెజెంట్ చేస్తూ ఉంటారు అప్పుడు గ్యాప్. నేను వాళ్ళు ఇది పెట్టుకుంటుంది ఇది చేస్తాను.
Good evening. We will wait for 5 minutes and then start at 7.
Good evening, sir.
Good evening, Nikhil. Good evening.
Yes, sir. Good evening, sir.
Good evening, Dr. Naresh.
Hi, sir. How are you? Good evening.
Good evening, everyone. It's 7, so we can start. So just to give you a brief background of these master classes. Jaipur Surgical Tutorial is an online educational portal which we have been running for last 2.5 years at the Mahatma Gandhi Medical College and Hospital in Jaipur. It is being managed by my colleague, Dr. R. So these are morning classes which we run. 9 to 10 for students, but we thought that it would be good to have a session they cover. So we started these master classes a few months ago. We've already done 3, first on living donor liver transplant, then on safe cholecystectomy and chronic pancreatitis. So this is the 4th master class, second part. We covered 4 topics yesterday, and today we have some more topics. I would request all the speakers to please finish in 12 minutes when I will sound an alarm, so that we can give at least a few minutes to the chair and 5 minutes for Q&A from the audience. The questions will come on YouTube, which I will read out. The co-moderator with me is one of the senior most GI surgeons of the country, Dr. RA Sastry, who's at KIMS in Hyderabad after serving in Nizam Institute for a long time. He will be moderating the entire session for today. For the first talk, I would like to invite Dr. Naresh Mangalhara, who's a interventional radiologist at SMS Medical College. And the speaker will be Dr. Nikhil Bansal, who's our colleague at Mahatma Gandhi Medical College Hospital in interventional radiology. Dr. Naresh, please carry on.
Yeah. Good evening to all. Hi, sir. So today's topic, the first topic is percutaneous radiological intervention. So I think these days with the with the dramatic improvement in the technology of the minimal invasive treatment, that an intervention radiology treatment, pancreatitis management has completely or IR at least has a very good role in the management of acute pancreatitis, especially in the collections, in the pseudoaneurysms, bleeding. So, Dr. Nikhil, being an IR, I want to just know your perspective in the management of role of IR in the management of acute pancreatitis.
Am I audible?
Yes, sir.
You are not audible. I can't. Let me check here.
No, Dr. Shastri, I think there is a problem at your end.
Am I audible, sir?
Yes, yes.
Yes.
We are able to hear.
Okay.
So maybe Dr. Shastri, you can check your speakers, please.
So good evening, all the seniors. I'm Dr. Nikhil Bansal, working as an associate professor at the Department of Intervention Radiology at Mahatma Gandhi Hospital. Thank you, Naresh Mangalhara ji, Dr. Sahab. IR has an important role in terms of evaluating the patient, and starting with the evaluation of the patient. And the evaluation consists the most important part, I think, when to intervene and when not to intervene in a cases of a acute pancreatitis. So although it is a little bit controversial, or maybe different institutes have a different opinion about it, so majority of time we are definitely able to find out whether the collection surrounding the pancreas or within the pancreas is infective or not. In those cases where the imaging is not suitable, in those cases where the clinical correlation with the imaging is not suitable, in those cases the fine needle aspiration can be done, in which we can identify whether the collection is infected or not. In those cases where we are confirmed or sure about the infection is infected by the means of peripancreatic collection having a gas within it, in those cases, we can put a pigtail. Initially, our preferred choice is to put a small size of pigtail, and later on we can upgrade the size eventually. This can significantly decreases the chances of getting into the bowel, into the mistracking, and we can prevent the bleeding. Yes, Dr. Mangalhara.
Yeah. So, Nikhil, Dr. Nikhil, what is your protocol in your institution? How do you wait for some time or at least a few days or few weeks before putting a catheter inside the collection?
So in our institute, we have a strict regimen. In those cases, those who are admitted in our hospital after 5 to 7 days, there is a strict protocol. Then after we do the CT scan and evaluate whether the patient is having any kind of collection or not. If it is collection is present, whether the collection is suspicious for the infected or not. If we have a high suspicion for an infection, then only we do the intervene or do the any kind of intervention. In those collections, if we are not suspecting clinically or radiologically the collection is infected, we do not touch those patients. Even the FNAC is avoided, because usually we think the collection is an sterile collection. So in those cases, we do not intervene.
Right. So earlier it was said that we should wait for a few weeks before putting any catheter. But in our institute, when I was a trainee in ILBS, we have started to put catheter just when we are having suspicion of infection. We went for early intervention in this patient, and the output or prognosis was better in these patients rather than delaying the patient for a few weeks. Anytime you are suspecting an infection, you should intervene with the help of catheters and by other means.
Okay.
So, there are one problem that we usually encounter in these patients are that catheter blocks multiple times, and there are many pericatheter leakages, etc. So, how do you proceed to tackle these kind of problems?
So in our institute, we usually prefer to put a small size of catheter in an initial go. This can significantly decreases the misplacement of the catheter, as well as the chances of surrounding bleed due to the fragile vessel can significantly reduce. And later on, we can upgrade to prevent the blockage. We usually prefer to put a two tubes, maybe one with a larger bore and second is a smaller bore, and through the smaller bore we can do the irrigation part. And even if the tube get blocked, we can upsize the tube.
So, for putting two tubes for irrigation, do you have any plan for it so that the irrigation can be done according to gravity, or you just put two catheters anywhere, or you
No,
plan?
it is put according to the gravity. The larger diameter is done in a dependent portion,
Right,
and
right.
the irrigating catheter is put a little bit above it.
Yeah, or both the catheter should be in the continuation of the collection.
Continuation. Yes. Yes.
Right. And is there any surgical? Do you place surgical catheters also in these patients?
Yes.
Drainage catheters,
Yes.
large surgical drainage catheter.
Because the pigtail catheter and the follies are usually have a tendency to get blocked because of the larger debris size. So our preferable choice for starting with the Melicott catheter, maybe a smaller bore, and later on we replace it with the surgical large bore catheters.
Yes, yes. Advantage of sometimes surgical catheter is that the holes are very big and there are multiple holes, multiple big size holes. So it is many times it is usual when the debris is quite thick and the even the larger Melicott catheters are getting blocked multiple times.
Yes.
And what is the role of vascular intervention in these patients? It's
In
quite
those
common.
cases, okay. So our preferable is if the patient is presented with the any kind of bleed, even if we are not able to find any kind of pseudoaneurysm, if it is leaking or we see an extravasation or we are suspecting any kind of spasm and it's surrounding to the collection, we are very much sure about that. If the patient is clinically deteriorating and the hemoglobin is decreasing, then our preferable choice to go ahead with the DSA angiography and look for the suspicious vessel and embolize it.
So you get CT angio done prior to the procedure, or you go directly in the
It all depends upon the general condition of the patient. Our preferable choice to go ahead with the CT scan, not to go directly intervene as an invasive procedure. But in those cases where the creatinine or the organ failure is suspicious or the either creatinine levels are high, in those cases we do the selective angiogram with a VC pack.
Okay. Okay. But these days, even gastroenterologists are doing pseudoaneurysm coiling through endoscopy route. They have started to do these procedures. So,
Yes.
what is happening in your institution?
Currently, we are the one who are doing the embolization.
Okay. Okay.
Yes.
Can I ask you? Good evening, Kalla sir.
Yeah, please tell me.
Sir, is there any role of endoscopy guided management of pseudoaneurysms?
Yeah, this is something which is really coming up nicely now. So there was recently a paper from PGI Chandigarh, which says that vascular interventions by US. So the coiling, thrombus injection, glue injections, those things now they are gradually picking up. But
That's
as a convention in routine, I mean these things are not practiced, but gradually as our learning curves are improving, we hope that by another year or so, we should be doing these procedures as well.
But sir, there are basic difference between the IR approach and the endoscopy approach in the management of pseudoaneurysms.
Yes,
While
yes,
IR, we actually used different techniques to embolize not only the aneurysm sake but also the arteries supplying that
yes,
pseudoaneurysm.
yes,
But on by endoscopy, all gastroenterologists are putting a coil or embolizing agent directly into the aneurysmal sake only.
yes,
So
yes,
the inflow and outflow is patent, and many
yes,
times the outflow in these pseudoaneurysm, outflow also acts as an inflow if we proximally
yes,
block the artery.
yes,
So I think if we look at the theory part of the pseudo basic management or basic principle of the pseudoaneurysm management, it is quite tricky to block the pseudoaneurysm by putting the embolizing agent directly into the sake rather than blocking the supplying arteries. So I think it is little bit unbelievable for me as a IR that how can, because as a IR we are always taught that we should not embolize the pseudoaneurysm sake. A true aneurysms can be embolized, sake can be embolized of the true aneurysm, but pseudoaneurysm sake we should not embolize. We should rather embolize the feeding arteries and the outflows. So, but let's see, it is a new emerging technique.
yeah,
So it might prove beneficial in the coming future. So,
yes.
Dr. Nikhil, what is your experience in the pseudoaneurysms in the pancreatitis? Which vessels are usually involved in these patients?
Uh, Usually the branches of the GD are the most common who are the culprit for the bleed.
Okay, what is your experience about the splenic artery branches?
We have seen a few cases of the splenic artery also.
Actually, in SMS, we are routinely getting large splenic artery pseudoaneurysms. Earlier, we used to think that GDA is the most common culprit artery, but we are now these days we are getting a good number of splenic artery pseudoaneurysms also.
Yes. So I have encountered more than 10 cases of the splenic artery pseudoaneurysms also. But out of even the scoring is somewhere around 20-30% of it, 70-80% are still the GDA branches.
Okay, and many times do you see the single feeder or multiple feeders of these vessels?
So eventually in a course of a patient, sometime we do during the complete course of a patient, if we block some artery, sometime the patient presented with a different artery bleed also.
Right. So, in the nutshell, I think the role of IR has emerged very nicely in the management of acute pancreatitis as well as its complications management also. So, now I think the house is open for the questions.
So, Nikhil, for the sake of the surgeons in the audience,
Right.
can you please summarize as to at what stage you would want us to refer a patient for percutaneous intervention of a collection in the initial, say, a few days or few weeks of acute pancreatitis?
Sir, our preferable choice to refer the patient once the patient got clinically deteriorated. And the second thing is, it all depends upon the CT, how it looks on the CT. Our preferable choice is to put a drain after a 4 week. Once we get a well walled off collection. In those cases where we are suspecting a clinical deterioration, in those cases where the walled off is being done and it is more than eight weeks, in those cases where we are suspecting a pressure symptom, in those cases we are highly suspicious for an infection on a CT scan in terms of a gas within the collection. I think those are the preferred cases which should be referred to the IR department for the percutaneous drain placement, sir.
But there are many patients who, even in the earlier days, say first 1 or 2 weeks, they have a collection and they have features of sepsis, and
sir.
we don't find any other source of sepsis. So, would you like to drain this collection?
Yes, sir. Yes, sir. If we are suspecting a infection at any time of any course of the disease, sir, we can put a drain, sir. But I think we should start, don't jump directly onto the very large bore like a 22 gauge or anything like that. I think we should start with the smaller French size of a pigtail, and should be later on, eventually should be upsize the pigtail or a drain tube, sir.
What about multiple or multi-septate collections?
In a multi-septated collection, I'm very afraid of if it is less than a 4 week, the chances of, if we do the septation break with the pigtail or with the any kind of drainage tube, the chances of bleed remains high because the surrounding vessels are very edematous. The surrounding structure is very edematous. If we rotate the tube and try to break the septations nearby the collection or within the collection, the chances of bleed remains high. In those cases, we should address initially the larger diameter of the collection and put 2 or 3 drainage within it, sir. We should not try to break those septations or try to break the nearby collection or try to communicate the 2 or 3 collection within it, sir.
What about transviscous approach through the stomach, through the colon?
Sir, our preferable choice is to go the retroperitoneal. Should be the first approach, should be the retroperitoneal approach, sir. If we are not able to do it, then the transgastric, transhepatic can also be done, sir.
But not through the jejunum or colon.
Usually the preferable choice is not, sir.
Dr. Sastry?
Yeah, these are all high skill sets which are not uniform all over. So you're not able to generalize any particular advice for a given situation. Say, for example, we had a hemosuccus pancreaticus after acute pancreatitis with a pseudocyst in the head and a pseudoaneurysm of the pancreaticoduodenal arch. Now, how exactly would you treat this?
Sir, this is a common, I think, a common entity in the pancreatitis in which we see this arc aneurysm. In this, we have to treat from both the celiac axis and from the SMA actually. Recently, we got this patient.
The caveat here is there is a pseudocyst which is communicating with the duct. Now, yeah, I'll tell you the experience. That is exactly what we have planned and did, and then ended up with blockage of the duct. The duct got blocked. In the process of embolizing the pancreaticoduodenal arch, the duct got blocked, and then they had a lot of problems with that, and ultimately had to do ripples.
Because
so, these are all tricky situations, particularly pancreaticoduodenal arch aneurysms are tricky. It's not always possible to do from SMA side and from the celiac side.
Exactly.
But the rebleeds are quite common in these situations.
Any concluding remark from Dr. Naresh before we move on to the next?
Sir, before that, just one more question. Anybody has any experience with percutaneous necrosectomy?
Naresh, we call it now necrostomy.
Right,
so what we are doing that we are upsizing the track, then we are taking our scope through the retroperitoneal drains. we have now small scopes and nice accessories, and we can clear it also. We have had experience of doing two cases who had like fistula 3 months even after the pancreatitis resolved. They are external fistulas, pancreatic fistulas. So through these tracts, we filled up the lesser sac and pushed in a drain from the stomach side, lesser sac, like routine cystogastrostomy. So these are new things which are coming up, wherein you now can't puncture from the gastric side because there is no bulge there. So you can use the access which you have created earlier 4-6 weeks later, and you can utilize it.
And so, what size of track do you use for this your scope?
The smallest thinnest scope we have is around 6.5 millimeters in size, which has a channel of 2.8 millimeters in it, through which the accessories can go. So at least if not, we would certainly need what 15 French or 18 French catheter.
Right. Okay, sir.
Has anybody got experience with transduodenal necrosectomy? Say the necrosis is presenting behind the duodenum, bulging into the duodenum, and you try to do it through the duodenum.
Sir, personally, I haven't heard of transduodenal necrosectomy.
Pradeep is not online, but I know a patient where they have done transduodenal necrosectomy repeatedly 4-5 times, and
sir, if you see the data about cystogastrostomy, ease and complications, the transduodenal approach, if you get a good bulge in the first part of duodenum, the complication rate is really less. So we are already creating a 1.5 millimeters stroma there. So though personally I have never done it through transduodenal approach, most of our patients we have done through transgastric approach only, but I think it is feasible. The only issue is the first time when you have access into the sac, that should be good, and after that there is no problem.
I think for the sake of students, I would say if it is a fluid collection or a cyst which is bulging into the duodenum, maybe using an endoscopic ultrasound to locate all the important structures. If you find a good window, you can just drain the collection into. But trying to do a necrosectomy transduodenal probably too much, and I don't think that we should.
I don't think we should advise
to the students in the audience.
I think if I may step in, I think I have had some experience in the early years with the drainage of acute fluid collections by the transduodenal approach, much thinner, very close access, and fluid collections I would drain very well.
Yeah.
But for a scope to go in and then take almost a right turn, bend into the retroperitoneum, to dilate, upsize, think of necrosectomy in that situation would be very difficult. I think Dr. Kalla will be talking about it in the next
I think we'll move on. Yeah.
On endoscopic pancreatic necrosectomy, the basic principle is to get as straight a track as you can get from below the GE junction into the collection, and then whatever are the extents of the collection, you are able to go through with the scope and do the standard necrosectomy procedure in that situation.
I think
yeah, okay.
Well, anyway, you are going to go chair. So thank you, Naresh. Thank you, Dr. Naresh. Thank you, Nikhil. At the moment, there are about 15 people who are watching it on YouTube, but we don't have to get disheartened because yesterday's session already had more than 450 views so far. So probably students will watch it later. So with that, I hand over to Dr. Saraswat, who was my colleague for a long time as the Chief of Gastroenterology at SGPGI Lucknow, and is now the Chief of Hepatology at Mahatma Gandhi Medical College Hospital. And the speaker would be introduced by Dr. Saraswat. Dr. Saraswat, please.
Right. Thank you, Vinay. I was and I still am your colleague here in Mahatma Gandhi. I hope you remember that. Now, I think we are coming to the endoscopic management of complications of acute pancreatitis, which is a fairly extensive field to cover. And it will be done by none other than Dr. Mukesh Kalla, one of the most senior and experienced interventional endoscopists in the state of Rajasthan and in Jaipur. Mukesh has an extensive experience in all areas of therapeutic endoscopy, and I'm sure he will be equally adept at handling the complications of acute pancreatitis. Mukesh, do you have a PowerPoint that you are sharing?
Yes, sir. I'll share the screen if you
go
permit.
ahead, and then we'll take on discussions after the PowerPoint.
Right, sir. So thank you, Dr. Kapoor sir and Dr. Saraswat sir for nice, pleasant words. So I have accumulated this data to make it concise and how things have changed since I have a practice of now 2 decades and how I learned gastroenterology and fluid collections way back in 98 and what we are doing in 2023 is altogether different. So as we all know, I mean, we'll go through about natural history of acute pancreatitis. 71% patients have a milder disease, but at the same time, 21% have necrotizing pancreatitis and 6% have a symptomatic pancreatic pseudocyst, which requires intervention. So if you go through the natural history of disease, in the milder form of the disease, up to less than 4 weeks, there is acute peripancreatic fluid collections, which later after 4 weeks will develop pancreatic pseudocyst. And for those patients who have a necrotizing pancreatitis, these necrotic collections after 4 weeks will become walled-off necrosis. Now, the major paradigm shift is about the definitions and approach to these two situations. So this is like picture diagram of how things happen. For a milder nature of disease, you have a side duct disruption or you have a major duct disruption causing pseudocyst. But when you have necrosis, then you invite risk for causing walled-off necrosis. Now, other complications of severe acute pancreatitis are infections, fistulae, pancreatic leaks, and pancreatic pseudocyst. Now, when we talk about endoscopy in acute pancreatitis, we can divide it into therapeutic intentions of endoscopy and diagnostic intentions of endoscopy. So for diagnostic intentions of endoscopy in acute pancreatitis is usually during the first 4 weeks of the treatment when you can, acute biliary pancreatitis, you can treat that. You can give feeding tubes, place NJs or NGs, and you can drain acute infected collections. But after 4 weeks is the major role of this endoscopy comes in. So if you see those patients of acute pancreatitis who have recurrent acute pancreatitis episodes, now we are wiser because we have a new equipment, this biotechnology called endoscopic ultrasound. This helps us to pick up small microliths less than 5 millimeters in size with the sensitivity and specificity of reasonably 90% plus. For doubtful stones as seen on ultrasound and pseudocalculus signs, this is one good diagnostic modality. And for pancreatic divisum, which is again an important cause for recurrent acute pancreatitis, endoscopy in these acute pancreatitis patients can be helpful in achieving the diagnosis. Now, what happens when you get a patient of acute biliary pancreatitis? So not all acute biliary pancreatitis will undergo a ERCP. So we need to know which patients are eligible for taking the advantage of this therapeutic procedure. So those patients who have cholangitis, who have bilirubin more than 5 milligrams, who have clinical deterioration, along with stone detected on common bile duct on imaging, which can be ultrasound or MRCP. So these are the patients who would probably benefit from ERCP. In my personal opinion, I consider ERCP in biliary pancreatitis as a very important step, and I consider it equivalent to doing a primary angioplasty because those patients who decompensate later have major complications. So for those patients who undergo early ERCP in biliary pancreatitis, they have a shorter stay, decreased complications, mortality and systemic complications tends to be significantly lower for those patients who have undergone timely and early ERCP. So as and when, I mean, these patients of acute pancreatitis, they develop pancreatic pseudocyst, they develop VON, they develop extended VON, disconnected pancreatic duct syndromes, and other vascular and luminal complications of acute pancreatitis can also be managed with endoscopy. So we will take up pancreatic fluid collection and how situations have changed over last 2 decades about the management of these two problems. So when you see a CT scan of a patient, on the left side is the pancreatic pseudocyst, which is clean, clear fluid with sequelae of interstitial pancreatitis. On the right side, you see walled-off necrosis, which would mean that the debris is solid debris. And through a simple 10 French or a 7 French stent, this debris won't come back. Todd Baron is one significant person in the sequence of development of, because he was the guy who in 2003 gave the definition of VON. So if you see the picture on your left side is pancreatic pseudocyst, and on the right side you see debris, that is called walled-off necrosis. Now, why this is important to differentiate between pancreatic pseudocyst and VON? Because if you go through this one particular presentation of Varadaraju from GI surgery 2011, you'll appreciate that the pseudocyst treatment success, whether surgical or endoscopic, is up to 93%, whereas VAN success was 93. This was in 2011. Things have probably improved since then. Adverse events are significantly more in VAN, and median intervention, number of interventions required are more in VAN, and length of hospital stay is also significantly higher in VAN. Therefore, it's very, very important to know beforehand and before contemplating a procedure as to what we're going to deal with. Now, when you plan about managing acute fluid collection in the setting of pancreatitis, there are three possible approaches. One is traditional management, which is the surgical approach. We have learned from surgical approach about basic principles of how these collections develop. What is the natural history of these development, these collections, and how do you prognosticate these collections? The second important thing which came up way back in 2003 was percutaneous drainage, when intervention radiologists stepped in, significantly improved the morbidity and mortality of these patients. And somewhere around 2011 came in endoscopic drainage. This also we became wiser with the development of endoscopic ultrasound and with the introduction of newer metallic stents, which were called LAMS. So if you consider surgery, it is a radical treatment. It has morbidity and mortality. There are few long-term complications. And now, but in today's era, it is used as a salvage therapy. If you consider PCD, it is good, and it has really changed the scenario how you manage these patients, but it inherent problems of multiple procedures, multiple upsizing, and 27% developed fistulas. And for endoscopic drainage, the multiple plastic catheters can be planned. There is no external catheter is needed. Suboptimal drainage of debris was there till the LAMS was in, but now with availability of EUS and LAMS, the scenario is improving further. So if you go through the data now, till up to 1990, it was only surgery. Then after 1990, gradually percutaneous drainage came in, and endoscopic drainage came in 2007 onwards. So this is a very interesting slide, wherein you see that from the year 1980 up to 1991, it's all open surgery till the year 2000. It was all about sending these patients. I remember in early 2003, 4, 5, and in the moment you see air inside the lesser sac, we used to call our GI surgeon and we used to open those patients. Patients did well, but there were a fraction of patients we lost also. So, but the important landmark papers which came in was one Panther trial, and another important study which was from Dr. Pramod Garg at All India Institute of Medical Sciences. These two studies were, I would say, landmark studies. 35% patients with infected necrosis don't need necrosectomy. Minimally invasive approach is better than open surgery. Conservative treatment is comparable in infected pancreatic necrosis. But now, since the Attention trial and Miser trial, these two trials have really revolutionized the changes in the approach to the pancreatic fluid collections. The endoscopic management is now compared to minimally invasive surgical techniques. So this was the Panther trial, which compared the endotherapy to surgery, and they found in the cases of VAN, and found is a landmark publication, I consider this, and was really multicentric trial, which changed the scenario how we look at management of VAN. So in this particular situation, you will appreciate that endoscopic treatment is superior to open surgery and non-inferior to minimally invasive surgical procedures. Now, when you go further into this Panther trial, you will appreciate that open necrosectomy, when it was compared with step-up approach of IR, the overall results and the further complications down the line, 5 years follow-up, the risk of diabetes, hernia, death was significantly lesser with the step-up approach of PCD. Therefore, I would say that PCD was superior to surgery as per this trial. Then there was another comparison of direct endoscopic necrosectomy, which was compared with the multiple PCD drainages. Again, this also said that endoscopic procedure was superior to placement of PCD in appropriate situation when available. Now, for pseudocyst management of the pseudocyst patients, if you see the chart there, the treatment success of pancreatic pseudocyst is 95% with endoscopy, 100% with surgery. In this particular trial, which Varadaraju, all the procedures were done with EUS, whereas the surgical procedures were laparoscopic. The complication rate with minimal invasive surgery was 2%. Length of stay was longer there. And in US, the cost was significantly higher in surgical procedures as compared to the endoscopic procedures. So as to say that endoscopic procedure is less expensive, better quality, and it has less morbidity. Now we have this another good paper which compared use of percutaneous drainage with the endoscopic treatment. It also documented that as compared to percutaneous drainage, endoscopic drainage was associated with higher rates of treatment success, lower rates of complications, number of interventions, and shorter length of hospital stay. And of course, there was no fistula formations. Now we'll talk about the finer details of endoscopy in acute pancreatitis. So when and which patient needs this? These are symptomatic patients, preferably after 4 weeks, persistent wellness, cysts, ongoing organ failure, outlet obstructions, extrahepatic biliary obstructions, compartment syndromes, bowel ischemia because of pressure, and leaks into pleural cavity or outside. So when you have to do endoscopy in acute pancreatitis, the significant questions you need to answer on the radiology is whether it's a pseudocyst or it's a VON or it's an extended VON. Whether you're going to use intervention radiology as your tool, endoscopy, or you invite your surgeon to take the lead role. Whether you're going to use lamps versus plastic stents, and which is the optimal timing for doing these procedures. Again, Todd Baron is one very significant person who has contributed significantly to the understanding of this particular disease. And better to delay, this was the result of pointer trial, at least 4 weeks till the walls mature, so that there are no leaks in the abdomen, and we create a controlled internal fistula. So when you do endoscopy, there are 3 approaches here. This can be transpapillary, but the transpapillary is used through a routine ERCP scope. Plastic stents or nasocystic drains can be placed. So transmural approach is cystogastrostomy from the posterior wall of the stomach into the lesser sac where you have the collection. The moderate to large size opposing lumen to be accessible provides window for necrosectomy. This is important. And I was trying to answer the question of our IR colleague. The percutaneous endoscopic approaches can also be utilized, which is called tractogastrostomy, can also be done. These are new novel approaches for post-PCD fistula management. Now, what to do?
Two more minutes, please.
Right, all right, sir. I'll go faster. So whether it should be a EUS or a conventional endoscope, significantly there is no difference if there is a bulge, but if there is no bulge, preferably use a EUS. So lamps or no lamps, lamps is better than having a plastic stent. So now about data, the advantages with the lamps is 1.6 centimeters wide stent is available, drains most of the debris. You can go with upper GI endoscope repeatedly. Costly equipment, demanding technically, and unfortunately not much data is available as of now. Now, a little word about disconnected pancreatic duct syndrome, because this is one thing which, if it is there, it will probably negatively prognosticate your treatment. If you see these patients who have disconnected pancreatic duct, their surgical interventions requirement are more. Their need for reinterventions are more. Therefore, one must try to assess whether their patient has DPDS or not. Therefore, to say and to conclude, you delay, you drain, and you debride. This is the approach one should apply. And what are our limitations of endoscopic procedures? They are distant, without impressions, extended VON, endoscopic expertise if not available. Altered anatomy also precludes the use of endoscopy. Vascular complications. This is something new which is coming at the horizon of EUS, but there are limitations and the learning curve is still on this. So this is nasojejunal tube can be placed without pushing too much of air. Then you can manage pancreatic leaks by doing a pancreatogram and pointing out the location of the leak. And other novel uses of endoscopy in acute pancreatitis will be OTSC application, US guided thrombin coil placement for pseudoaneurysm. These are things which are gradually coming in. So the carry-home message, this is one what we are using at our hospital. In approximation with the stomach, if you have a big one with less than 30% debris, we request our endoscopist to do it. But if it is a significant large, more than 30% debris, we request our laparoscopic surgeons to come and take over the patient. If there is no opposition and the debris is less than 30%, then we request our radiology colleagues to take up, or open or laparoscopic surgery can also be done. But yes, if it is more than 30%, then these patients would probably require open surgery, stable radiological setup, open surgery, stable, or laparoscopic procedures can be done for these patients. Thank you for patient listening. I'll be happy to answer queries if any.
Dr. Saraswat.
Yeah, okay. Thanks, Mukesh, for an extensive coverage of a large area which is also rapidly expanding.
Yes, sir.
Series trials have come in, and innovations are the rule. As time goes by, before one particular procedure matures, a superior procedure is available. The instrumentation and the technology for the endoscopist is also improving.
Right.
So I think coming back to walled off pancreatic necrosis, who does what? I think you would agree that the recent guidelines that have come out from the European Society of GI Endoscopy, as well as position papers from the American Society of GI Endoscopy, also tell us that triaging the patient and finding out who is going to be the best responder to endoscopic therapy is becoming increasingly important. Advantages, I think I'm sure the time was just too less for you to cover all these.
Yes,
In a
sir.
sick patient in the ICU who is a very high anesthetic risk, bedside procedures and drainage and even necrosectomies can be carried out. And one limitation that you pointed out was distant collections that are far away from the stomach, paracolic or in the pelvic, in those areas. That is where I think the percutaneous endoscopic necrosectomy technique that you mentioned as tractogastroscopy, that away from the stomach, you can still use upsizing the percutaneous tract and then using the endoscope to get in and do this. I think the All India Institute people have published some experience with this.
Yes,
So
sir.
versatility is quite good. So between ward, the minimally invasive surgical procedure versus endoscopic pancreatic necrosectomy versus percutaneous endoscopic necrosectomy, and how do you see these different procedures, and which patients would be suitable for which of these interventions?
Sir, I think, if the collection is less than 30%, these are the patients which were best managed by endoscopic procedures. If you have one which is more than 30%, then the laparoscopic results probably would be better than doing endoscopic cystogastrostomy, because this is one subpopulation of patients where even in spite of having a 1.5 centimeters opening with the lamps, the gets clogged in again and again, and there's risk of sepsis in these patients. So probably this particular subset of patients would be more for minimally invasive surgical patients, but I am pretty sure that IR patients, IR for necrosectomy of 30% is not an appropriate solution. So it will be, the better results will be with endoscopy or vis-a-vis minimally invasive laparoscopic surgery.
So for endoscopic pancreatic necrosectomy, you go in with the scope,
Yes,
and there
sir.
are a lot of different schools of thought, whether you should use hydrogen peroxide or not, whether you should actually try and remove debris or only remove what is shed and away from the walls,
Yes.
and problems of major bleeding, because vessels can be disrupted if you are aggressive in removing necrotic tissue. So what is the approach that you follow at your center?
Yes, sir. At our place, we are using the Roth's basket, or anything which helps us to go in and accumulate the necrosis and bring it out. If you call about if you ask me about what is new in the horizon, there is like endorotor or necrolite. There are two new technologies which have come in, and they have passed the phase 3 trials in US and heading for the approvals, wherein they have created the aspiration catheters of up to 3.8 millimeter in size, which have rotors inside, and they suck out the necrosis, and they mince it in smaller pieces so that there is no residual area. As for H2O2, I am still doing it, but if you ask me about what literature says, this is my institutional practice and my decade-old practice, that after having done placed the lamps there, we go in and try to bring out as much as possible, and we come back with a nasocystic drain in place. We request them to place hydrogen peroxide repeatedly. But the data is, I mean, equivocal about use of hydrogen peroxide.
Yes, I think these are.
If, Jyoti, there is a question in the chat, if you can take that. That how do you estimate the amount of debris? Because you said less than 30, more than 30.
Yeah,
So radiologically we assess it, sir.
It's a radiological estimate.
Yeah, we normally we have certain precautions we do right before the procedure. We have we do a ultrasound, then we do it under EUS, which is a reasonably good modality to assess the amount of necrosis present in it.
Between these two images, I think MR imaging is generally thought to be superior to
Yeah,
CT
MR is
for
supposedly a better
assessing the
image.
quantity
Yeah,
of pancreatic necrosis.
correct, sir.
US gives you a very good idea, but if it's a very large cavity that all of it you can't image in a
Right.
few fields of US, it may be difficult to get a quantitative idea more precisely. So that is
Right.
where MR imaging would help a lot in making out percentage of necrotic debris in there.
Right, sir.
Right.
Concluding remarks, Dr. Saraswat.
Right. I think it's such an extensive area that it's very difficult to just have a few remarks. I think among the various procedures that are being done by the endoscopist, one that is gathering a lot of attention and good evidence-based data are emerging is for walled-off pancreatic necrosis and different approaches to tackle it effectively. Similarly, for disconnected pancreatic duct syndrome, the approaches are for draining can be supplemented and can be managed. But for GI bleeding, I think the IR approach is generally considered superior because it is more versatile. Whereas for splenic artery aneurysms on the left half of the abdomen, the percutaneous access is quite easy. And I think Dr. Naresh was pointing about the principles of angiographic management, while his point that he made from the angiographer's point of view are absolutely correct. But in aneurysms in the pancreatoduodenal arch or on the right half of the abdomen, because of the extensive vascular supply, I think there is no good long-term follow-up data of successful endoscopic management of glue. Most of it is in the splenic artery aneurysms that they've been followed. In fact, Dr. Pravi Rai from SGPJ has also published a good case series of patients in whom he has done one of the first publications was his. And I think his long-term follow-up of almost 1 year was complete recovery and a very, in the about a small series of about 10 or 12 patients, there was no rebleeding. But yes, I think handling what I think Dr. Sastry pointed out on the right half of the abdomen, aneurysms with multiple areas of vascular supply, it is difficult to have good control over the endoscopic technique. And I guess the angiographer using various techniques would have to see how best they can manage it. Unless there are questions from the house.
No, I think we'll have to move on. So thank you.
One point I want to add in this. Sir, you are telling about the right and left half of the abdomen, and pseudoaneurysm in the left abdomen can be managed by percutaneous route. But in a practical way, when we were not having cath lab in our department, we used to tackle these pseudoaneurysms by percutaneous route, and we used to inject usually thrombin in these pseudoaneurysms. But in our experience, we have seen that the percutaneous route is not that efficient, even the dealing with the pseudoaneurysm.
Right, that is the IR experience. I'm just telling you the endoscopy experience with glue injection and not thrombin was this small series that I'm aware of because from my department in Lucknow. We had followed about 1 year, about 10 odd patients, and they didn't recur. So I guess these are small experiences. These are short durations of follow-up. So it is very difficult to be very categoric about one or the other. These are again techniques that are evolving. But the versatility of these approaches needs to be kept in mind. In fact, the endoscopist got this idea from the percutaneous injection technique of the IR guys in the US.
Okay,
right.
I think we need to move on. So thank you, Dr. Saraswat. Thank you, Dr. Kalla. And I hand it over to Dr. Sastry to chair the next presentation.
Yeah. Okay, I think the discussion can go on and on. Let's get on to the, I don't have the program.
Yeah, it's Ibrar for
Okay.
indications and
Yeah,
timing.
Ibrar is ready there. Let's have Ibrar without wasting any more time. And then maybe at the end, we can have a combined discussion of the various approaches. Dr. Ibrar.
So while Ibrar is putting on his presentation, Dr. Ibrar is one of the first batch fellows from SGPGI, and he's now a senior consultant GI surgeon at Apollo Hospital in Bhubaneswar. Ibrar, please.
Good evening, sir. Can I share my slides?
Yes, yes, please.
Where is that button? Share screen.
Bottom,
Okay.
bottom now.
Right. We got it, sir.
Yes. Yeah, we can see.
One
Full
second, sir.
full screen kar lo.
Kar liya?
Yes.
It's full screen here at my end.
Yeah, please go ahead.
Right. The topic assigned to me is surgical management of severe acute pancreatitis, the indications, timing, and the approaches. Speaking, this we have already discussed. The indications of interventions are clinical deterioration with signs or strong suspicion of infected necrosis, ongoing organ failure in sterile necrosis, usually after 4 weeks of onset of the disease, ongoing gastric outlet, biliary or intestinal obstruction due to large walled-off necrotic collection, ongoing pain and or discomfort and intolerance to oral diet. As this has already been discussed, most of these indications, present day can be managed by non-surgical means. That means by way of endoscopic intervention or by radiological intervention. Most of this can be really handled. Leaving only a very small proportion of patients for surgical intervention. So strictly speaking, this is the exclusive group where the surgery is required. Otherwise, if the radiological or surgical or endoscopic intervention is the facility is not available, then all those indications would be indications for surgical interventions as well. The exclusive indications are as a continuum in a step-up approach after percutaneous or endoscopic procedure, abdominal compartment syndrome, a very poorly understood entity, acute ongoing bleed when endovascular approach is unsuccessful, acute necrotizing cholecystitis during acute pancreatitis, and fistula extending into peripancreatic collection. Infection is rather rare in the first week, but it goes up to about 60 to 70% by the end of the 4th week. The diagnosis of infection or infected pancreatic necrosis is mainly based on clinical, characterized by fever, leukocytosis, and persistent organ failure that is going beyond the 2nd week. Beyond the 1st week towards the 2nd week. Then elevated levels of serum procalcitonin on 2 consecutive days is very suggestive of pancreatic infection. Then imaging, of course, is the main diagnostic modality for pancreatic infection or the infected pancreatic necrosis. Particularly if you get a picture like this, the air bubble inside this necrotic cavity, inside the pancreatic necrosis, this is in fact the sine qua non of pancreatic infection or the infected pancreatic necrosis. Then, of course, CT-guided FNA microscopy or culture is the definite way of establishing infection. But then, with this again, we come to a very contentious issue or the very sensitive question, that is, what is the role of CT-guided FNA in the infected pancreatic necrosis? No doubt this is considered the ultimate proof of infection, but the point is, should it be performed routinely to confirm infection? Answer is, as you'd see in 90s when we were students, in fact, this is almost a fashionable thing to talk about CT-guided aspiration and microscopy to establish infection, and that becomes an indication for surgery. This is when the early intervention of necrosectomy was recommended in a deteriorating patient. But then early intervention is associated with a very high mortality. Therefore, in course of time, this has been abandoned. And the current practice is to wait for at least 4 to 6 weeks before taking up intervention. And this intervention is purely on clinical grounds, not by demonstration of infection on FNA. What I mean to say is, even if you demonstrate infection and the patient is stable, you are not going to intervene or not going to do any necrosectomy, and vice versa. Patient is unstable and you are not finding any evidence of infection on FNA, yet you would intervene. So therefore, the conclusion is CT-guided FNA in infected pancreatic necrosis is an abandoned procedure for the purpose of intervention as of today. Now, again, a debatable thing, intervention for sterile necrosis, because majority of cases of sterile necrosis can be managed conservatively. But then interestingly, nearly half of these patients when operated upon show positive culture. That means even if they don't show signs of infection, yet there is infection in half of these patients. Therefore, ongoing organ dysfunction or intolerance to oral intake beyond 4 weeks, even in sterile necrosis, should be an indication for intervention. Early necrosectomy was recommended with this premise that removal of the necrotic tissue would lead to decrease in the systemic inflammatory response, which in turn would lead to reduction in MOD as well as in the mortality. But then if you intervene early, the demarcation is still not clear. Therefore, you would require more settings to do a clear of the necrotic tissue. And in the process, surgery can induce infection in a sterile necrosis setting. Besides, this has been seen, this surgical intervention in this early stage can aggravate systemic inflammatory response. And this is associated with a very high mortality to the tune of 50 to 60%. Therefore, early surgery really did not serve the purpose it was intended for. This was a prospective studies back in 90s, where early necrosectomy was compared with late necrosectomy, but then this trial was terminated prematurely because of the very high mortality associated with early intervention, 58% compared to 27% with late necrosectomy. So this trial was eventually given up, was not continued. This is another study published in 2017, where the timing of operative intervention at 3 different cutoff levels were compared. Intervention at 72 hours, 12 days, and 30 days, excuse me. And what this study showed that late surgery resulted in a clear survival benefit over early intervention. Therefore, as regards timing of intervention, for at least 4 to 6 weeks before taking up any surgical intervention. If required, if the patient's condition demands, you can switch to or you can fall back on radiological or endoscopic intervention beforehand, but not surgical intervention. For surgical intervention, it is preferable to wait for at least 4 to 6 weeks. Because by this time, the demarcation is clear and the debridement becomes easy, and you can do a more complete job in less number of attempts. Mode of intervention, as we have already discussed, it could be radiological, endoscopic, or surgical. Just for completion's sake, I'll quickly mention the CT-guided percutaneous approach. Basically, this is done for 3 reasons. One is as a definitive procedure, particularly if there is predominantly liquid component in this necrotic cavity, then CT-guided drainage alone would suffice. Or else this could be a bridge approach in the early stage of necrosis when the patient is not doing well. You want to drain out this necrotic collection, then you can fall back on the CT-guided drainage. Or this could be part of the step-up approach as been the practice now. And thirdly, this could be prelude to a video-assisted retroperitoneal drainage or the peritoneal necrosectomy. As you would see, you need a tract, and that is the initial tract is established by a percutaneous approach, CT-guided percutaneous approach. The trial has already alluded to, and this is comparing endoscopic approach with surgical approach, and this is what the conclusion was that the new onset and persistent cardiovascular dysfunction was higher in the surgical group. There's no difference in the mortality. Hospital stay was longer in the surgical group, and pancreatic fistula is higher in the surgical group. So it looks like the endoscopy had an edge over surgical intervention in this group of patients. And now coming to surgical necrosectomy, this could be open surgery, could be minimally invasive surgery, which can again be transperitoneal laparoscopic approach, hand-assisted, conventional robotic, or transperitoneal transgastric approach. Or this could be retroperitoneal approach. This is known by various names like minimally invasive necrosectomy. This is minimally invasive retroperitoneal necrosectomy, so on and so forth. But the most accepted terminology is word, that is video-assisted retroperitoneal drainage or sinus endoscopy. The transperitoneal approach, that the conventional laparoscopy, what we do, the advantages are you can have an access
Dr.
to
Ibrar,
the. Sorry?
We have Dr. Rajesh and Dr. Pradeep talking about the procedures. I think if you have completed the indications.
This is a quick mention of this. Yeah.
Okay.
The advantages are this: you can have an access to otherwise inaccessible area, whereas disadvantage is laparoscopy is difficult in the distended bowel, and pneumoperitoneum could be really hazardous in a very sick patient. I think I can show this video if it plays. There's a video-assisted retroperitoneal drainage. As you can see, the initial percutaneous catheter has been placed. This is percutaneous catheter, and this is the guide wire is passed, and this tract would be dilated by using PCN catheter. We borrowed it from our urology department. There's a guide wire in the cavity now over which this PCN catheters would go. This is PCN catheter goes one over the other in the process of dilating the entire tract. Once you have a sizable dilatation, then laparoscope cannula is placed, 5 French cannula. Yeah. Through which we do a copious irrigation, and then there's a 5 mm scope is passed through that. That is why this is called sinus endoscopy. This is the necrotic cavity, which is, you can see it's a very clear cavity with some residual necrosis here and there. It does not really require any necrosectomy. All that you have to do is leave large bore catheters in the cavity, irrigate, and this loose necrotic tissue would eventually come out. And this has happened in this patient.
2 more minutes, Ibrar.
Okay. Yeah, I think I did not cover this. This will be covered by our next speaker, I suppose.
Yes.
So this is open necrosectomy, which may be required in a specific, in some patients where there is not much of peripancreatic necrosis, it's only necrosis confined to the pancreas, then you may use this. So this is a recent study that compared minimally invasive necrosectomy with conventional surgery. The conclusion is significant advantage of MIS over open necrosectomy in terms of post-operative multi-organ failure, incisional hernia, neo-onset diabetes, and use of pancreatic enzyme supplementation. But then there was no difference in the mortality rate or the pancreatic or intracutaneous fistulae. So the summarizing presentation, indications of surgery is failure or non-availability of interventional procedures like radiological or endoscopic procedures in patients who require intervention. And the timing is for surgical intervention is at least 4 to 6 weeks after the onset of the disease. And approach in order of preference is retroperitoneal approach, minimally invasive transperitoneal approach, and open necrosectomy. Thank you. This is a recent article which this PhD postgraduates can refer to for knowing more about this, surgical intervention and things. Thank you.
Thank you, Dr. Ibrar. Are there any questions?
The only point I would like to say, what Dr. Ibrar said, that even if we are reluctant to operate upon these patients in the early stage, but if one of the indications of intervention is present, then one should try to resort to either radiological or endoscopic intervention to tide over that period. So that is a very important point which he has made.
Yeah, nowadays we don't talk of
Hello?
indication for a particular intervention, but indication for any intervention. The indications are same. It is just infected necrosis with clinical deterioration. I think that is what the residents should remember as an indication for an intervention. Shall we go on to the next one? Yeah.
Yeah, Ibrar, there is a question from Dr. Anirudh Dhar. How should a colonic perforation be dealt with in a patient with infected necrosis? Should a diverting ileostomy only be done, or should it be combined with a retroperitoneal debridement also?
I would think if you're going in, obviously you'll do a debridement and do a diversion colostomy or ileostomy, whatever the thing you feel appropriate at that stage. It should be both, not just alone. But stoma is a must. That is one thing for sure.
I would even go a step further that if CT scan or the operative findings suggest that colon may be involved in the necrotic process, the wall may be ischemic or suspicious, even if there is no frank perforation, the threshold for doing a diverting ileostomy should be low, because that is what is going to save the life of the patient. And on the other extreme, if the colon is obviously gangrenous and has opened up at multiple places, or there is a large perforation, then some kind of a segmental colonic resection may also be required, because unless that colon is removed, the patient may not improve in terms of sepsis. So colon is a very important organ which has to be considered when dealing with necrosis.
Shall we go on to the next stage?
Yes, please. So next session will be chaired by Dr. Rebala Pradeep, who's the GI surgeon at Asian Institute of Gastroenterology in Hyderabad. And Pradeep, you can introduce Rajesh.
Can you hear me, sir?
Yes.
Okay. Thank you. Rajesh, everybody knows he is the professor of head of surgical gastroenterology in PGI Chandigarh, and he has a lot of work published on pancreatic necrosis, and I think he has delivered a lot of lectures even abroad and India. Any acute pancreatitis necrosis, the first name comes to an Indian scenario is Rajesh Gupta. It's all yours, Rajesh. You can go ahead.
Thank you, sir. Thank you for this kind invitation, kind introduction. And I must thank Professor Kapoor for this opportunity to speak to this august audience. My brief is to speak on minimally invasive necrosectomy. There will be some overlap with the previous talk, and I like to see that it does not get overlap. Sir, are my slides visible and am I audible? Hello?
Yes, both.
Okay. So I think we have moved away from the early times when in late 90s we used to treat pancreatic necrosis with a knee-jerk reaction of necrosectomy, and this seminal publication from David Ratner from Mass General Hospital, which actually stated that if patients are treated initially with percutaneous drains, they lead to longer hospital stay. They spend more days in ICU and more days of TPN. So hence it was recommended that aggressive initial surgical debridement should be the first step in managing symptomatic pancreatic necrosis. But we soon realized that when we were following this approach, there was considerable mortality and morbidity. And I'm sure Dr. Rebala is going to dwell on this in his talk. I'm just sharing our experience when we were practicing this approach. This is data from 92 to 98 and then 98 to 2004, which was published subsequently with 2 intervals. And we found that during the later part of the period, when we started increasingly using percutaneous intervention before surgery, and also started delaying the interval of surgery, the mortality decreased from 47 to 29%. So thus, when we look at the whole thing, arose the need for a lesser surgery, because it was felt that reduced surgical trauma would lead to reduced pro-inflammatory response, which would probably result in lower new onset organ failure and also associated lower incidence of enteric fistula. So these are the results which were from a study which came up a couple of years ago. Not only that, even the long-term morbidity like exocrine endocrine dysfunction as well as incisional hernia incidence were low and the mortality was lower. Then this comparison from multi-centric, this is actually 6 centers across transatlantic and close to 2,000 patients where they found that open necrosectomy was leading to more surgical trauma and pro-inflammatory response. And this was leading to higher incidence of organ failure. And this organ failure was the major determinant of mortality, especially when we are talking of infected pancreatic necrosis. So minimal invasive surgical approaches, which I'm going to discuss, Dr. Ibrarullah has already enumerated them. So what is predominantly utilized when the necrosome involves the tail of the pancreas and the left pararenal area? The other approach that we are now increasingly using in our practice is transgastric necrosectomy, when the necrosome is predominantly in the lesser sac with a bulge in the back of the stomach. And then a new, I think it on the blog now is minimal incision necrosectomy, where necrosis extends in multiple peripancreatic areas and actually is a complement to other minimal invasive procedures. However, I must emphasize again here that a CT scan should be repeated prior to these procedures as a roadmap, because when we, as Dr. Ibrarullah said, that we are using percutaneous catheters as a routine for step up in all these patients. So there may be change in the size of the necrosome, and that can affect our approach to these necrotic cavities when we are contemplating the route. So I'll start off with the video-assisted retroperitoneal drainage in a 54-year-old male who had gastro-induced pancreatitis with CT severity index of 10/10 and had single organ failure at that time. He underwent PCD insertion at end of 4th week. He was on irrigation for 2 weeks, showed initial improvement, which is the usual course, but then again started having multi-organ failure. And at that time, in the 7th week, this was the CT scan which was done, which shows large amount of solid necrosome both in the tail and also extending towards the head and body. And this is what we did. This is when we use the percutaneous catheter for approach. The catheter tract is dilated, as Dr. Ibrarullah has already shown. So I'm going to actually skip because there would be probably repetition. But this is just one way of approaching this cavity, that is using that percutaneous catheter and dilating that tract with dilators, and generally these are ureteric dilators. And over that catheter, we generally put VC port so that we know exactly where we are entering. One has to be very careful about the surrounding organs like spleen, kidney, and colon, which are in the vicinity and can get damaged. So other approach is using ultrasound guidance when placing these ports, and that is actually required. If you see, this patient initially had a large collection, but after he had a pigtail catheter, that collection size shrunk because the infected fluid was drained, but the solid necrosome continued to be the source of infection, and this patient required surgical intervention. And then in this patient, there were 2 catheters. One was this through the intercostal space, which we could not use, and the other catheter, which was in the paracolic area. So from that, with the guidance of ultrasound, we localized this intra-abdominal collection and then went in. So after we enter, so after we put in a first catheter, we generally put 2 and sometimes 3 also if the collection is extending into the paracolic area, and the third catheter is superiorly. So once we put in the first catheter and we suck out the fluid through that port only, then we use ultrasound to look at the cavity and introduce the needle, and then this needle acts as a guide wire to put the second catheter. And then the debridement is done as has been shown earlier by Dr. Ibrarullah. And then this is a third approach in those patients where the PCD is lying for a long time, there is a loosening of that tract. And actually in these patients, we probably do not need any further dilatation. All we need to do is just put a skin incision around this and then secure the approach to the cavity by using a pigtail over this catheter and then dilate till the anterior rectus sheath by an instrument which is blunt tipped, and after that is dilated, then entry into the catheter is generally digital. All this is being shown that we need to minimize the trauma of the port insertion, which at times can be significant and can actually lead to conversion to open procedure. Also in this, one would see that at the end of the procedure, you see sometimes thrombosed vessel, and once we see that, we can generally put a clip at the end of it, and subsequently we can place drains as we are seeing in this video. So this is put under vision, and we generally put 2 drains of large size. We use Foley's catheter because they are generally non-traumatic, and even if they stay for longer time, they are, benign tubes. So coming to the next procedure, which is transgastric necrosectomy, this has been actually popularized by this study from 3 centers, from Stanford, from University of Indianapolis, and from Calgary. And the 3 centers have published around 200 patients, and the indications have been collection in the lesser sac with a bulge in the back of the stomach. This is a very effective counterpart to laborious repetitive endoscopic transgastric necrosectomy, as this is a one-time procedure. And because we provide almost 5 to 6 centimeter of opening into the posterior stomach wall, which we do cystogastostomy, it ensures durable internal drainage and also addresses the disconnected left pancreatic remnant. Also, we don't need to put any stent or anything to keep it patent, because those stents, if left for longer time, can lead to erosions and bleeding, and all these lamps or even these stents are removed subsequently. So transgastric necrosectomy can be done both by open and laparoscopic approach. I am showing a video of a laparoscopic approach where there is a large necrosum, which is we can see that bulge on the stomach as we enter the cavity, and after the anterior gastrostomy, we make a hole in the posterior wall. Of course, we have to make sure that all these openings into the anterior as well as the posterior wall of the stomach are at appropriate position. And once that opening is made, we can remove large necrosum. And all this, as I said, we don't need to go in again and again to remove tits and bits. Of course, the risk is of general anesthesia, but then prolonged endoscopic procedures also at times require anesthesia. And at the end of the procedure, we see a cavity which is clean, has granulation tissue, but here you see a vessel which probably is thrombosed, and we are not sure about the actual nomenclature about this vessel, but since it can bleed subsequently, so all these tissues which we find could be potential bleeders, subsequently we put clips intraoperatively. Coming to the last part, which is minimal incision necrosectomy. This is when, as I said, necrosis extends to multiple areas. So part of this can be approached by ward or transgastric necrosectomy. But then probably if the collection is in the head of the pancreas or extending on the right side, which cannot be approached by the other two approaches, this approach can be used. So generally, we have a pigtail already in place, and this we have to put a muscle cutting incision, which is 4 to 6 centimeters total, maybe sometimes bigger. The idea is, again, as I said earlier, we do this, we reach up to the muscle posterior rectus sheath. We do not enter that sheath. That is generally done digitally. And then after we enter, then that tract is enlarged. And then digitally, necrosome can be mobilized. As we have seen that most of the cases, wherever we do minimal incision, the necrosome can be reached by the fingers of the surgeon. So this is a patient who actually had ward through left paracolic collection and then subsequently developed right paracolic collection. As you see here, this patient already had ward done, and now he has developed collection in the right side. And then all we need to do is just put an incision on the either side, open that cavity and drain that infected fluid. And then since there were two drains, so we irrigate both these tubes. We have recently published our experience where we had shown that compared to open necrosectomy, minimal incision and ward actually had significantly lower post-operative hospital stay. Post-operative bleeding was surprisingly less with minimal incision compared to ward. The mortality was lowest again with minimal incision. So my take-home messages from this would be surgery for IPN is to be individualized based on the disease process and the anatomic distribution of necrosis. A multidisciplinary MIS approach to the management of necrotic pancreatic is associated with improved morbidity and mortality compared with open necrosectomy. Integration of various techniques is basically required for comprehensive management in these patients for improved outcome, and that may also include in future combining ward with even percutaneous endoscopic approaches where we have given an access and endoscopists can probably take care of the paracolic areas where surgically we have issues because that flexible endoscope can reach those areas. Thank you, sir.
Sastry, please.
Yeah. That's a good presentation, Rajesh. The take-home message is vital. The individualized approach, when you have multiple techniques, how to individualize the technique is crucial. And the second one is a combination of techniques. That is what we have learned. It's not a single approach for all the patients, but a combination of from minimally invasive approaches in a step-up fashion. That is the main take-home message. Thank you. And then if there are any questions on the...
Not on the chat. If Dr. I don't know whether Dr. Kalla is still there. There was a question and a comment by Rajendra Desai on the earlier talk. Okay, I think we will move on. So the next session was to be chaired by Ajay, but I don't see Ajay there. So maybe I will introduce Dr. Rebala Pradeep, who's, as I said earlier, the senior GI surgeon at Asian Institute of Gastroenterology. And he's going to talk to us about open necrosectomy. Pradeep, please.
Can I share the screen, sir?
Yes, please.
It says host has disabled participants screen sharing.
Himanshi, can you please make Dr. Pradeep co-host? Just a minute. Oh, Ajay is there. Ajay, please come in. Dr. Ajay is my colleague. He's the Chief of Surgical Gastroenterology with me at Mahatma Gandhi Medical College Hospital. Ajay, are you there? Himanshi, can you? Yeah, okay, Dr. Pradeep is there. Yeah, Pradeep, please go ahead. I'll sort out the matter why Ajay is not seen.
Yeah.
Please go ahead.
Okay, thank you, Dr. Kapoor. I'll be talking on the open necrosectomy, which is the indications are going down with the advances in the minimally invasive. And somebody has already shown that last 30 years we have moved from open surgery to minimally invasive. The most important thing is the timing. So that we have two, the first phase is the 14 days, first 2 weeks, where it's more of inflammation. You're not very clear-cut demarcation between viable and the necrotic tissue. And the second phase of 14 to 28 days, where the demarcation starts appearing, and that's where the necrosis starts separating out. And that's where actually the infective complications also set in. And if you look at it, the necrosis, when there's severe pancreatitis, the inflammatory mediators are very high, and that's where it produces a systemic immune response to the patient. And then when the infection sets in, and then you can start developing the multi-organ dysfunction. And then when you add a surgical trauma, you can add in more trauma and more inflammation, and the organ function can deteriorate. That's what we understood in the last 30 years or so. And then came the concept of a minimally invasive. So the treatment obviously differs in the first phase and second phase. The first phase is morely conservative and prevent infection. And it is the second phase where once the necrosis starts appearing, and the treatment is directed basically to the local infective complications. And when they develop multi-organ functions, the supportive care and the debridement of this necrotic tissue comes in the later phase. And we know about 30 to 70% of patients develop infection, and that infection is responsible for the high mortality which you see in this group of patients. Though there are some series which have showed that even infected pancreatic necrosis can be managed medically with appropriate antibiotics as well. And the risk of infection increases depending on the extent of necrosis and the time of onset of pancreatitis. So the longer the time duration between the onset and the time interval you see, the infective complications goes up. The goal of any of these necrotic is the removal of the pancreatitis exudate from the peritoneal cavity and the lesser sac, removal of the infected necrotic pancreatic and peripancreatic tissues, and also preserve the viable pancreatic tissue. And after removal, if there is post-intervention, you do require some sort of interventions to evacuate the remaining debris and exudate. And at the same time, all this should be achieved with low mortality and low morbidity with both short and long term, and should be cost-effective. This should be the goal of managing these pancreatic necrosis. And if you look at this, the step-up approach, which has been popularized now, as the intensity of the tissue trauma increases, obviously the success of the necrosis removal also increases. The least traumatic, obviously the removal of necrosis is much smaller, so you do require multiple sittings. But when you go more aggressive approach like open necrosectomy, the tissue trauma increases, but the efficacy of complete removal of the necrotic tissue increases. So you should balance out between these depending on a case-to-case basis, or a combination of the procedures which Dr. Sastry has highlighted just now. These are the two landmark trials which showed us that the minimally invasive is much better than the open necrosectomy. Though the Panther trial did find that there is no difference in mortality between the minimally invasive and open necrosectomy, but subsequent studies of pooled data has shown that definitely the mortality is much higher in case of open necrosectomy compared to the minimally invasive necrosectomy. So this has led to the algorithm of a step-up approach, where the first and foremost is a conservative treatment. And when the infection develops, when it cannot be managed with ongoing antibiotics, then comes a percutaneous drainage or an endoscopic drainage. If the patient improves, probably you can continue the treatment. If there is no improvement in the patient's condition or the new onset organ failure develops, then one should resort to a minimally invasive neck ward or a laparoscopic necrosectomy. If still you cannot achieve a good clearance, then probably a laparotomy and removal. Or if there are any associated complications develop in the initial phase, like bowel perforations or a hemorrhage, which cannot be managed by interventional radiologists, also is an indication for a laparotomy in this group of patients. So with all this data, now is open necrosectomy is obsolete. I don't say that it is obsolete, but there are certain situations where open necrosectomy comes into play to save these patients. But if you look at the old data, it shows that we talk of high mortality in these patients of open necrosectomy. Now you're going to understand that if you wait for 4 weeks, even mortality of this open necrosectomy can be brought down as low as 10%. The other important factors of adding mortality to open necrosectomy was these factors which has got a high, these factors which can produce high mortality are because elderly patients or patients having comorbidities, or when there are multi-system organ failure which cannot be controlled by medical treatment. So these are the cases where the open necrosectomy is associated with high mortality. If you look at these pooled data, it shows if you categorize these patients into low risk to high risk based on the pre-existing risk factors, if you can see this, so if it's a high risk patient, probably they can find a significant advantage with minimally invasive procedures. But when you come to low risk, there's not a much difference between the mortality or morbidity between the open versus minimally invasive. So though the numbers are very small in this study. So what are the advantages of open necrosectomy? You can have a better visualization of the tissues, which some reports have mentioned this, but I disagree with this concept. Actually, you can have a better visualization with a laparoscopy. You can get into the cavity more clearly, like what Rajesh has shown, that you can see a vessel and you can clip it. But other advantage is you can access all the quadrants of the abdomen, which minimally invasive is very difficult to access, or even endoscopic or a percutaneous, you have to have multiple ports. And it's a one-time procedure, and reintervention rates are less than 25%. Because if you are able to achieve complete clearance with open necrosectomy, reintervention rates are much lower. And also you can add ancillary procedures, like you can have a feeding jejunostomy to these patients, because nutrition forms a major component in getting these patients out of these sick patients from ICU. And you can also handle associated complications like bowel perforation or fistulas, more commonly seen in the large butt, particularly the splenic flexure area, and an uncontrolled bleed, which cannot be managed sometimes with a endovascular therapy. You can have, particularly the portal venous branches, bleeding not be controlled by endotherapy. So probably you might have to open these patients and control these patients by suturing the site of bleed. The other disadvantage of open necrosectomy is you can develop an external pancreatic fistula, which sometimes might be difficult, particularly when there's a disconnected duct, or a long-term complications of pancreatic insufficiency, which tends to be much higher in open necrosectomy, both in diabetes as well as the exocrine deficiencies. So what are the indications today with open necrosectomy? When there is a step-up approach, there is no improvement in the patient's conditions, or the patient deteriorates, or when there's an abdominal compartment syndrome, which usually seen in the first few weeks of the therapy, or when there is an anatomically widespread necrosis, both paracolic gutters and lesser sac and mesocolon. So probably an open necrosectomy might be appropriate for clearing of all these necrotic areas in one procedure. And a bleeding complication is not manageable by endotherapy or a bowel ischemia, or when there is an expertise not available for these minimally invasive procedures. But if the patient is low risk, probably yes, one can go ahead with the open necrosectomy. But the patient is a high risk even for open surgery. I think one should consider shifting these patients to higher centers where such facilities are available, as we know that high risk patients, minimally invasive, produces less mortality. So for open necrosectomy, these are the standard approaches, particularly transgastrocolic. That's what normally we approach lesser sac. And now you can even approach transgastric, which Rajesh has shown the using a laparoscopy, but open also you can get into the transgastric and remove these. The other approach, less commonly performed, is the transmesocolic approach. So transgastric necrosectomy is suited only when the necrosis is limited to the lesser side. The advantage of an open transgastric necrosectomy is it is less invasive and it prevents a pancreatic fistula, because even if there's a pancreatic fistula, you establish a communication with the stomach. And it is done by a small midline laparotomy, anterior gastrotomy, and then you enter the posterior gastrotomy and then debride all the tissues and secure a hemostasis under vision. And one can put a continuous approximating stitches between the gastric wall and the fibrous wall of the cavity, so that the remaining secretions of the necrotic debris can drain into the stomach. And even if there's a pancreatic fistula, it forms a communication with the stomach. The principles of the open necrosectomy is, of course, is adequate exposure. Incision either is a transverse epigastric or a rooftop. But this is more comfortable rather than a midline incision, because these patients might have a poor wound healing, and hernia is a big problem. So a transverse epigastric or a rooftop is what we normally use, and access the necrotic cavity. A gentle debridement with an instrument or a finger flush is what is required to remove all these debris, which can be easily separated. And you can explore into the left paracolic if required, and by incising the left paracolic gutter, and you can communicate the lesser sac into the left paracolic gutter. You need not separate the splenic flexure, because you are going behind the transverse colon and into the colon into the paracolic gutter. So you can convert into a one cavity. But however, the right paracolic needs separate incision, because you cannot, it is not communicated, it cannot be communicated with the lesser sac in these situations. If the necrosis is confined to the head and neck area, you can approach either by the mesocolic route near the head towards the right of the mesocolic artery, middle colic artery, or you can cauterize and drain it, or necrosectomy can be done from behind. And this is how you put your finger and deglute, and you can also use irrigation using a septo syringe and flush out all these debris, which can easily separate. And this is a short video which shows how you use a sponge holder forceps to easily remove all this necrotic debris. And the most important instrument, I would say, would be a finger, by which you can easily separate these necrotic debris from without traumatizing the wall of these cavities, which are highly vascular. And sometimes you might even find vessels running across. So one should be very careful in breaking these vessels. You can actually induce bleed in these. If you find such things, as Rajesh has shown, that you can ligate or even a clip. Here we can here we prefer to ligate, because it's an open necrosectomy. We can ligate these suspicious vessels. Most of them, though, are thrombosed. We are not sure. So it is better to ligate these rather than blindly breaking these rigid cords. After that, irrigate the cavity with saline by using a force, and you can pack. If you find some ooze, which normally you find some bit of ooze from the wall, you pack it for some time. Usually the bleed stops. And then leave about big drains, 28 French drains into the cavity, which you are use as a irrigation, also on draining these subsequent secretions. So the most important component, how do you manage the residual cavity, is the next question. So the three popular ways which can manage these cavities are open packing, and then you intervene. But it could be a planned reintervention when you find a lot of debris left behind, which is not clearly demarcated, or on demand when the patient is deteriorating, or when you find on a CT scan that some more debris is there or some collections is there, probably then you can re-enter and then clear the debris. And the open packing is by heal by secondary intention. The other mode of managing the cavity is a closed packing. So here again, you use reinterventions, but you don't close the abdomen, but you produce a graded closure of the wound edges, so that by the time all the necrosis is completely cleared off, the wound edges will come together, and which can be closed at the final when the cavity is completely healed. The other way of handling the cavity is can achieve a primary closure with a and put drains, as I have shown in the previous video. And these drains are used for irrigation of the cavity till complete debris has been removed. So this is the slide. It shows how an open approach is. You use a transverse incision, gastrocolic ligament is divided, and you debride the all the necrotic tissue, and you put the pack and then cover it with a plastic sheet so that it doesn't dry out. And then you plan after 24 to 48 hours, go in again and debride it. So initial 1 or 2 might require anesthesia. Subsequently, as the granulation comes in, you might do at a bedside. So you keep doing it till the wound heals by secondary intention. And once the wound completely fills, the cavity fills by the granulation tissue, you can cover by a skin graft. But the only problem with this is it can lead to an incisional hernia. This procedure is more appropriate, particularly when a compartmental syndrome is seen and where you can't approximate the edges. So, but nowadays, most of the very few centers do this. It was very popular in the olden days, but nowadays people are resort to closure by using this graded closure. This again is the same principle, but once the majority of the necrosis is removed, once the tissue edema has come down, and we close the wounds by using either a mesh or a PTFE. So when you're going in for a next time, you open in the center and clear off the debris, and then you keep approximating these by using a zip or a Velcro, so that the wound keeps slowly coming closer, so that the sheets on both the sides will come closer. So this graded approximation, and subsequently when the necrosis, when the granulation has occurred and the cavity started healing, and the wound edges will come together, so one can close the. So you can see this. We use a technique. We cut the proline in between and then overlap both the flaps by using a proline suture so that the wounds get closer. So at the later part, when wounds come really closer, then you can close the wound. This is another technique of approximation of the edges by using a whack. I don't have any experience with this technique, but they use a whack to bring the wounds together. Over a period of about 3 weeks or 4 weeks, the wound edges come together. And the whack also acts as a suction of all this necrotic debris through this. And once the wound edges come together, then one can close the wound. The most popular in most of the centers is using a lavage method. This is not applicable when when you can't close the abdomen without tension. So if the abdomen can be closed without tension, then this method is appropriate. Use a multiple wide bore drains are used. Preferably use one drain as an outlet for the neck debris and the other inlet for infusing fluid. Usually the first 1 week, 5 to 7 days is what we use an infusion. We usually use about a liter or so, once in the morning and once in the evening. And the flow should be very at a high rate, so that you are using this flow as a debridement mechanism. The flow debrides the tissues, which comes out through these wide bore tubes. But the initial description was they use for about almost 40 liters or 50 liters, but we don't use that higher flow rate. We use about a liter or in the morning and a liter in the evening to use it for debriding the residual tissues. So this is one of our patients where you can see the Foley's catheter as an inflow, and there's a tube which is a bag attached to it as an outflow. And at the same time, had a colonic communication. So we did a diversion ileostomy. And most important is open necrosectomy. We add a feeding jejunostomy because nutrition is very important. Most of these patients, we can't achieve the targeted nutrition. And depending on the parenteral nutrition is very expensive in our country. So we prefer to use a feeding jejunostomy to maintain nutrition in this patient. So what are the results of these various procedures of open method? The open method, the mortality is to 10 to 18%. Closed irrigation method, the mortality is slightly lower. But the problem with the open method is enteric fistula, a big problem with this, because you remove the pack each time, there can be trauma to the intestine. So whereas in a closed irrigation methods, these fistulas are uncommon. But the only problem with the closed irrigation method, you might find some residual collections which gets walled off and forms a secondary infection and abscess. But nowadays, if you find such collections, it's easy to drain by using an ultrasound guided drainage. So the preferred choice, if there is no compartmental syndrome, we use a closed irrigation method is a preferred choice in our center. To conclude, there is a shift in the management of pancreatic necrosis. It is a multidisciplinary. The most important point one should realize is delay and do less invasive in these patients, which will which can produce low mortality and low morbidity results. But open necrosectomy still has a role in select patients. And even in open necrosectomy, we try to delay as far as possible, particularly about a month or so for demarcation to appear. And we prefer to do a one-stage necrosectomy and then a lavage. If you have to open, in the early intervention is required because of the multi-system organ failure, then one should use an open packing in these patients because preferably the indication remains to be because of the abdominal compartment syndrome. The advances in emergency care and delay in surgery has decreased the mortality from which was 40 to 50% 30 years back to 10% now. Thank you.
Ajay is there. Ajay, unmute yourself and come in, please. Ajay is my colleague. He is the Chief of Surgical Gastroenterology at Mahatma Gandhi Medical College Hospital. There is a question in the chat box. Pradeep, maybe you can take that and then Ajay can give some comments. Ajay, unmute kar lo aap apne ko.
I have unmuted. I think Dr. Rebala can take that question.
Yes,
Any
Pradeep,
recommendation on the type of irrigation?
Yeah.
So the question is from Dr. Jyoti Kharel. Any recommendation on the type of irrigation fluid, temperature, volume, rate, intermittent or continuous, and what is the end point?
Yeah, so it is a room temperature. We use a normal saline, and the recommended is about a continuous irrigation for 4 to 5 days, and that will lead to about 40 to 50 liters as per the publications. But we routinely use about a liter or so, and flush it with a fast, and morning once and evening once. That's what we usually use, and we continue for about a week or 10 days usually what we use it. And the end point obviously is if you don't find much of a debris coming out is an end point. So as long as the debris is coming, we continue to use it. And we have not found any residual collections by using this. Probably if you use a high volume of fluid, probably some of the fluid might seep into areas and they might get loculated and they might get secondary infected. That might be the reason. But we are comfortable with using about liter in the morning and liter in the evening twice a day is our policy.
Ajay?
Yes, sir. I think very rightly said by Dr. Pradeep. This is exactly what every resident learns during his residency time, that whenever you are irrigating with the fluid, you go for the round, you go and see the patient, just flush it with a volume, say something around 200-300 ml volume, and you will find some coagulum or the necrotic material coming out through the drain. So this implies that you need more irrigation right now. So you can't end the irrigation at this point in time. So as long as the coagulum or this necrotic material is coming, you need to irrigate. Some of the points I think which
can I make a point?
Yes, sir. Please.
Yeah, please go ahead, Ajay. Please.
Ajay, go ahead.
So some of the important things, say, sir has said that about pancreatic fistula. I think the pancreatic fistula rate is same whether you do it by laparoscopic or open. It is because of the ductal disruption which happens with both. And the pancreatic insufficiency is also a characteristic of the necrotic tissue. How much of necrosis is there? The most important part, I think, was Dr. Pradeep has very validly said is that this open has a role either in the initial period when you want to decrease the compartment syndrome, or when you have a complication, whether it is colonic or if you need a feeding jejunostomy. I think, Dr. Pradeep, that's what is the consensus right now.
Yes, yes.
So these. And if you have a bowel ischemia or a bowel involvement, laparoscopy is a disaster, because then irrigating the entire peritoneal cavity with the necrotic tissue as well as with the enteric content becomes a nightmare, because then it will form multiple pockets of collection, especially in the pelvis, which are difficult to be managed. Next important.
Although we have discussed about colonic involvement, but can you, for the sake of students and young surgeons, can you please highlight the importance of colonic involvement and the role of diverting ileostomy, please?
Sorry.
So we do find sometimes this colonic communication might be obvious if you do a cologram, but sometimes it's very difficult. You might not be able to document it. These communications might be very minimal. So if you find that a lot of gas which cannot be explained, or if there is a dilatation of the colon proximal to the splenic flexure, and or unusually the patient has a loose motions which cannot be explained with antibiotic induced diarrhea. So we have a high degree of suspicions. Though we err on the side of creating an ileostomy, and and most of our patients have done very well with that. So many times it might not be easy to document the communication because these communications might be very small. But sometimes you might be able to, if you do a cologram in these patients, you might document a fistula.
Yes. So three things which are actually available with only with open and never available with laparoscopy, we have to understand is your finger,
yes,
the spoon holder, and the suction, the plastic suction that you have. Whatever good the suction in a laparoscope may be, but these three things cannot be replaced in laparoscopic. And specifically in open surgery is required when you have multiple pockets. The multiple pockets of collection, I think they cannot be treated, whatever we may try. And in today's time, in today's era, the procedure is indicated after multiple attempts of intervention radiology, people putting a drain. So now we are intervening only when whatever possible but to be drained by a minimal invasive procedure has failed. And this is the time when there may be some role of laparoscopic or a minimal invasive or a major role of open now. So this is the area where only open can tackle it better. Do you agree with me, Dr. Pradeep and Dr. Rajesh?
I just have one comment regarding the use of pigtail catheters, because this rampant use of pigtail catheters as a step-up approach after Panter trial is leading to a lot of disaster now. What is happening is the radiologists are putting catheters and the patients are showing initial improvement, and we are leaving at that point. And these patients subsequently, even after they show initial improvement, then they slip into sepsis and multi-organ failure. And that is the time when surgeons are called into play. And I think that is making the surgical mortality higher. If after putting a catheter, these catheters are taken care of, because it is a very labor-intensive procedure. I mean, we have published our series of around 1100 pigtail catheters in Journal of GI Surgery. And we have shown that if we use these in a proactive manner, we can actually avoid surgery in 60%, but we are not doing that. So I would caution here that if we are putting pigtail catheters, then please ensure that they are draining, and we can actually use them as irrigation catheter alone, and that can lead to definitive management itself.
I think the most important is, as Dr. Sastry has highlighted, that it's a multidisciplinary approach. I think at this point of time, when intervention is required, I think we should have a combined meeting of the interventional radiologist, the endoscopist, and the surgeon together in planning the treatment, which usually never happens. At least in our center, for the last 5-6 years, we started, it is mandatory that we discuss, the surgeon, the endoscopist, and discuss and plan the management so that everybody is on the same page. So that's most important if you want to achieve good results. But even then, sometimes it's very difficult to get all of them onto the same page and agree to a protocol or a diagnosis.
No, Dr. Pradeep, I'm making a different point. What I'm saying is that this use of pigtail catheters, and these patients then gets referred to your center. And most of these patients then have already developed multi-organ failure. Yes. And that window period of surgical intervention has been lost.
If I remember correctly, yesterday there was a discussion, and it was very rightly said by Dr. I forgot who was telling this, that daily it should be a combined, daily or at least on alternate day, a medical person, a surgical person, a critical care person, intervention radiologist should see daily. It can't happen that the intervention radiologist say suddenly, "Ab aap le lo isko, kal se aapka." It can't happen. I think that is a wrong approach. Or a surgical or a medical gastroenterologist says, हमने बहुत डाल लिया है, अब नहीं होगा, अब आप surgery करो इसका. I think that is a wrong approach. Better approach is all the three of them combinedly take it up daily basis and then take a consensus statement. And the surgeon says, नहीं अब आप और मत करो. Now let me do it. I can handle it better now. At least at some point in time, surgeon should have a say. Surgeon should not be at a mercy कि अब आप संभालो.
No, even the Panther trial itself very categorically said that after a DANE is put, after 48 to 72 hours, if there is no improvement in the clinical condition. So they are not looking at any radiology. They're just looking at clinical condition. If after 48 to 72 hours, there is no improvement, re-image these patients, see if there is undrained collection, put another catheter. Again, see after 48 to 72 hours, if there is nothing which is drainable, patient continues to be in sepsis. This is a time to deal with this solid necrosome which has not been dealt with. So, I mean, this is a continuous care. It is not that, you know, I mean, I have strong reservation about the way these patients are dealt with. I mean, this is not
a last 5 minutes, Dr. Shastri's.
I think it's important to view all these techniques in their proper perspective. Comparisons are difficult because of the high heterogeneity of the patients and the clinical situation itself. The number of necrotic areas, the locations of the necrotic areas, the skill sets, the available expertise. See, all these matter considerably. So my advice to the junior colleagues is not to get confused or influenced by biased comparisons. You know, there is bound to be some bias when you are talking, you know, exclusively or say a open necrosectomy or a percutaneous approach or an endoscopic approach, because the success would totally depend on the timing of the disease, the process, the timing of intervention, the anatomical constraints there, and the individual clinical scenario, how good is the clinical situation of the patient is. All these matter much more than, you know, when you compare. I think these things will have to be considered, and it is quite difficult. But ultimately, what the current evidence we have to accept is the step-up approach has come to stay. And step-up approach with a percutaneous or endoscopic, followed by either minimally invasive or open, based on the expertise available and results at every stage carefully monitored. That is very important. It's not only the timing of the first intervention, but the timing of the second and third interventions are equally important, as Dr. Rajesh was mentioning. I think these are the points which you should emphasize to the junior colleagues, rather than the techniques and you know, the successes or comparisons. Comparisons are difficult here. So these are
one point, you know, when they compare the results, they look at composite endpoints.
Yes.
And that composite endpoint includes pancreatic fistula.
That would be the real endpoint. Yes, after all the procedures.
And I mean, pancreatic fistula we create. Pancreatic fistula we create. It is not a complication. I mean, that is a way of dealing with this necrosis. Idea is to save that patient in one go, in one sitting, as early as possible. So if you include that as a composite, then you show that the morbidity is higher in surgical procedure. Mortality in both Panther, in tension is actually lower.
The problem is, in spite of the consensus about definitions of all the clinical situations in acute pancreatitis, the range of the severity is quite different in each situation. They are not comparable. Still.
That is true.
Whatever the statistics may show us, the statistics may show something for a particular group of patients, but the residents and the junior colleagues should understand you have to treat this patient in this scenario and this point in time. It can't come up from the whatever is been written or the vague aspects which have been given. So this is the patient that is more important.
Okay, I think it is 8:59. I will take the last minute to thank Dr. Shastry for staying full session both days and moderating, to all the speakers, all the chairpersons. I kept watching the YouTube live. I was also a little unhappy and disappointed that the number of viewers today live was small. But as I mentioned, that yesterday's sessions already had 450 views. So I'm sure that the subscribers of Gastro University, which is the creation of Avinash Tank in Ahmedabad, and Jaipur Surgical Tutorial students probably would watch these sessions at their convenience. I think that is the way teaching is today, that we deliver and they take it when they want it rather than one-to-one. So with that note, once again, thank you everyone, especially the guests from non-surgical departments. And once again, thanks to Avinash Tank and his team. Himanshi, are you there?
Yes, sir.
Yeah, come in, put your camera on, let everybody see you. Manshi, the
Yes.
technical support for all the Jaipur Surgical Tutorial activities, and we are very grateful to her. Thank you very much. Thank you. Thank you, everyone. We'll close the meeting. Thank you.
Thank you, sir.
Thank you. Thank you.
Good night.
Thank you. Good night. Bye.